Some of us had a reckoning as to how much work's involved just taking a few simple orders. You take a few simple orders, you gotta transcribe them, then you gotta go do them, and you gotta chart what you do. Right? It was a lot to that. That was fun. I had a blast yesterday. Hope y'all had just as much fun. But in particular, document as soon after as you can as what you've done in terms of assessment or whatever you do. Whether it's computerized or paper charter, though we are getting closer and closer to that timetable where everything's going to be electronics. It's one of the biggest obstacles is when they finally have the nursing homes to go to electronics. That's going to be interesting. Yes?
Question on the documentation. If you have a Spanish-speaking patient, are you to write in Spanish as well?
No, you'll write in English.
Okay.
You'll write in English. But you will make sure that you have interpreter. You know, if you're not fluent, it's the law. It's the law with hospitals. They're mandated that they must have interpreter for being able to interpret and speak their first language, especially when they're up for surgery procedures. So if you're bilingual, you're plus. It's excellent. I recommend everybody go. If you have to do some sort of electives, take Spanish. Right? Conversational Spanish would be good. That gives you a leg up in your jobs. When you consider about the patient's condition and their state, and they want to describe something, use quotation and literally put it in quotation, describe in their own words. Write that in the notes. Don't write a book though. You know, you hang yourself. Write a book. Those lawyers, they gotta make a living too. Cues. There's some recording or record cues. And cues are what the client says and what you observe. Now, your textbook says avoid using the words appears and seems, and sometimes I still use them. I do, because I was from the old school. But really, if an incision is read, it is what it is. Incision read, just say it, not appears read. See, I was taught from the old school when they would tell us to use these kinds of verbiages. So you'll still see nurses charting that way. But we're trying to bring you up to snuff, up to current standard. So it is what it is what I'm saying. And then you can refer to your textbook 51 to 52 about more information about documentation. Plus you're going to have a good experience Thursday. Right, y'all can confirm you had a good experience yesterday, right? So we want to do more like that. Now we've moved on to chapter 4. Chapter 4, do we need a bathroom break? Yes, no, can we continue? Because we're going to get through this and then I'm going to break you up in your groups. Okay, nursing process again. Still in there, second phase diagnosis. Second step. The second step is where you'll analyze your assessment data that you gathered. Remember with the assessment, that's the first step. It's got to be very complete data. Because how can you logically identify an actual or potential diagnosis unless you have correct and accurate data? And you, the RN, is the one that's going to be in charge of that. You, the RN, not your subordinates. Now, before the 1950s, the nurses assisted the physicians by collecting data to help them diagnose and treat. We didn't really have this concept of nursing diagnoses We did things. There were our list of things to do. And it was all geared toward the medical diagnosis, you see. But we're a powerful group. Our nursing is a powerful group, and we realized that nursing diagnosis was very instrumental, and it was a separate entity from the medical, but we can collaborate to help the outcome for our patients. So there's actually, you can go to page 58 in the textbook and you can see how they compare the differences between nursing diagnosis and medical diagnosis. What we independently can do as nurses, we can identify interventions to help the patient thus treat in respect to nursing care. So a patient who has nausea, and this is just an example, what we could do is make sure that environment that they're in is a quiet environment. We can comfort them, we can put their head, a bed up, we can provide them the cool washcloth. Comfort measures, see? Decrease the stress levels. That's what we can do as nurses. We had a similar exercise that we talked about what we could do as nurses, and you two, those students that have skills lab Thursday and Friday, you'll get an opportunity to have greater understanding of those nursing measures that one can do to help patients. Changing a position, giving a back rub. Where did the back massage go? It went away with so many more tasks, right? It's very hard to get that evening back rub in anymore. But we need to remember that. Don't forget it. When I'm your patient, I do want my back rub. I do want it.
I taught you that.
NANDA, that's the creation of the nursing diagnosis. Big conference, big entity that was developed in its North American continent. Actually, the Canadians and the Americans, they come together, and must be a huge conference. I'll have to go to one of those one time. You guys don't forget y'all want to go to conferences as RNs. Use them as a business trip, right off, and take your family. You know, Orlando, Florida, whatnot. You know, make fun. You know, have fun with your family. You know, Disneyland, whatever. But in your textbook, in that CD, I did note that they actually had the NANDAs listed in there. I think I want to say it's either chapter 3's section or it's either chapter 3 or this chapter 4, that you can find that. Nursing diagnosis versus medical diagnosis. We talked about that just a few slides back. Nursing diagnosis is stated in terms of human responses, reactions to disease, injury, or stressors. A medical diagnosis is looking at that pathological condition. They are different. Let's see what this YouTube is. I forgot what it was. Who knows what it is? I have to turn the volume on.
My name is Becky Stivers, and today we're going to discuss writing a nursing diagnosis, and it really is easier than it looks. A nursing diagnosis is simply a statement of what's actually going on with your patient at any given time. You've got your NANDA nursing diagnosis books, so that you can pull an actual diagnosis out of that book. However, you need to make sure that it pertains to what's going on with your client. Make sure that you do not use a medical diagnosis, as this is about nursing diagnosis. So what are the steps? How do you begin creating your nursing diagnoses? Well, the first step is going to be gathering data. You're going to take vital signs from your patient. You're going to do your physical assessment of your patient. You're going to look at their history and physical and their admission database. All information that you're going to put together and cluster on something that we're going to discuss later called the concept map. You're going to analyze and interpret this data. First, you're going to make sure that you validated the data, that it's true, and you're going to cluster it on your concept map. This is going to enable you to identify the primary problems or needs of your client. Then you'll be able to formulate your nursing diagnosis statement based on these findings. As I've mentioned, the nursing diagnosis is derived from actual or potential problems that your patient's at risk for. They're derived from either physiological, sociocultural, developmental, and/or spiritual dimensions of your client. The focus for the nursing diagnosis is on helping the client to achieve a maximal level of wellness and their highest level of independence. It's important to differentiate between nursing diagnoses and medical diagnoses. The primary care provider comes up with the medical diagnosis, and this deals with the disease process or the medical condition that's going on with your client, and their focus is on treating that disease or curing it. Nursing diagnoses are very different because they deal with the human response to either bio, psycho, or social stressors, and health problems that a nurse is licensed and competent to treat. And that's a major difference from the medical diagnosis. There are two primary purposes for nursing diagnosis. The first is for the client. It's a way for us to create individualized care for the client and make sure that we're selecting appropriate interventions to help optimize their health. It also enables us, in partnership with the client, to establish goals for optimal health. Now for nursing, it really does facilitate good communication. We're documenting what we're doing, and it provides for continuity of care. For instance, in the hospital setting, one nurse could create the plan of care. The nurse who follows could come after, read what has happened, the patient's response, and move forward with her care. And this really does provide continuity of care and great communication between providers. There are three parts to the nursing diagnosis statement. The first is the patient's need or problem. You're going to be able to determine what that problem is by looking at all the assessment data on your concept map. It's what's going on that's the problem for your patient. The related to, this is the cause or etiology of the problem. What caused it? So for example, if the patient's problem right now is pain, the related to could be a surgical incision, because that's what's causing the pain. As evidenced by, these are signs and symptoms or evidence of the problem. If I were to ask you, how do you know your patient has pain? The as evidenced by would be what you would tell me. In other words, patient rates her pain at 8 out of 10. Or the patient has facial grimacing every time she sits up. As you can see at the bottom, the patient's needs or problem must come from your NANDA approved statement found in your NANDA book. However, the related to must be what you come up with for your patient's cause, and the as evidenced by must be what you see as the actual signs and symptoms or evidence of that problem in your particular patient.
So you have to get the participant.
Let's take a look at a few example nursing diagnoses. As you can see, I've numbered them in order of importance for my clients. Number one is pain related to crushed tissue. as evidenced by patient complaints of pain, 7 out of 10, and facial grimacing when moving the arm. Number 2 is constipation, related to low fiber intake and decreased mobility, as evidenced by no bowel movement for 3 days and abdominal distension. And number 3 is risk for injury related to generalized weakness. Please note that when you have a risk for as a nursing diagnosis, there is no as evidenced by because it's not a real problem yet. There's a risk for it. Let's take a look at how to prioritize multiple nursing diagnoses. The first is an actual problem. This is a firm diagnosis that is supported by your findings. It's validated by data that you've collected. A high risk, this is where a patient only has risk factors, but does not have any actual signs and symptoms. This is the risk for we were just talking about. Your patient is more vulnerable to develop these problems, but they don't have them yet. And then there's possible problems. These are just tentative. Additional data is needed to confirm or rule out whether you could use this. Let's take another look at the 3 parts of the nursing diagnosis. The first is the problem. It's either an actual problem or your patient has a high risk for it. These are based on the data that you've clustered on your concept map. You're going to have subjective and objective data in your boxes on your map. Remember that the problem must be in approved NANDA format. Oftentimes it will begin with modifiers such as impaired, altered, decreased, ineffective, or risk for. The second part of the nursing diagnosis is the related to. Again, this information is also found in your concept map boxes. It's part of your objective and subjective data that you've gathered. Remember, this is what caused the problem. It indicates a relationship between the problem and its etiology, how it's related to one another. This cannot be a medical diagnosis, so don't let yourself be confused with that. The related to, or what's causing it, must be modifiable by nursing interventions. For example, if pain is related to pressure from laying on the right side, it can be modified by a nursing intervention of turning the patient every 2 hours. That would relieve that pressure and help decrease the patient's pain. The nurse must be able and licensed to do something about the related to. So again, if the related to was the pressure that was causing the pain, a nurse is licensed and able to turn that patient every 2 hours. And it will be in one of 5 categories. Either the related to will be pathophysical, what's going on with the pathophysiology of the client, environmental, situational, psychological, or maturational. And finally, let's take another look at the third and final part of the nursing diagnosis. As evidenced by, or sometimes it's written manifested by, depending on the instructor and where it's taught, is also found in your concept map boxes. Again, we come back to the fact that this is part of your subjective and objective data that you've collected. This is the signs and symptoms that led to your nursing diagnosis. So, pain is our problem. Pressure was the related to from laying on that right side. And the signs and symptoms for that pain would be the patient rating their pain, 4 out of 10. Grimacing when they're on their right side. Stating that they're uncomfortable on the right side. Some other examples are short of breath while walking. Client rating their pain 7 out of 10 in nursing. A client weight loss of 2 kilograms in the past week. The client hasn't had a bowel movement in 3 days. Or the client has an open wound on the right buttock measuring 2 by 3 by 0.5 centimeters. So you can see, it's pretty simple putting together a nursing diagnosis once you've learned how each component works together.
It's pretty good. And you guys will have a record of this as you go. Y'all have a record of this on your PowerPoints. Y'all can refer back to it as you're writing your care plans. She really talked a lot about concept maps. You guys won't be doing the concept maps this quarter, but next quarter you will begin to start doing concept maps. Collaborative problems. I'm going to cover this slide unless we'll take a 10-minute bathroom break, right? Collaborative problems, those are potential and the physiological complications of the disease. Here's an example what I come up with, and this is based from your textbook. Mr. Moore has a medical diagnosis of diabetes type 2, and as such has collaborative problems. Potential complications of hyperglycemia or hypoglycemia. All other patients with type 2 also have these potential complications. So collaboratively, you can see a pattern with patients that have this kind of condition, this kind of disease process. So you want to keep in mind that the collaborative problems, they're always potential problems. But if it becomes an actual complication, then it's no longer a collaborative problem, but now it becomes a medical diagnosis. So collaborative problems sort of become, if you want to think of it, is that risk, and when it becomes actual, it becomes a medical diagnosis, see? So remember that one slide of saying that seeing the difference between nursing diagnosis and medical diagnosis and collaborative problems? You remember that it was like 3 slides back? That's what we're speaking to when it terms of collaborative. But if it becomes an actual problem, then it switches and then becomes the medical diagnosis. So collaborative problems, they can have both a physician prescribed and independent nursing intervention that will prevent or minimize the complications. So as a collaborative problem, you see we could interact as a nurse and do some nursing interventions trying to avoid that becoming an actual problem. Because then it becomes a medical diagnosis. I know it sounds like a maze and a puzzle, you know, but in all, we're disciplines that are trying to help the patient with positive outcomes, the medical, the physician, and the nursing. You know, all these disciplines. So let's take a 10-minute break. Everybody be back in your seat at 10:40 according to the clock. I want to try and get, or is it right, 10:40? Yes. 10, when it's the big hands on the 8.